Am I audible?
Yes, ma'am.
Okay. This is a very small topic, obesity and infertility. I'm just taking an article from journal Fertility Sterility. This is done by American Society of Reproductive Medical Practice Committee report. It is a report actually. The considerations, everything I'm taking from the same article with American references. The global burden of obesity is, like as we all know, it is like about 12% of the world population, but accounting mostly American population of about 40 to 45%. Among Indian population, obesity is accounting for around 25 to 30% of the people. Definition of obesity, as we all know, we will take BMI as the like index. BMI of more than 25 is overweight and more than 30 is considered as obesity. Why we are so much considering about obesity is the rising trend of type 2 diabetes as well as cardiovascular diseases and infertility. Coming to gynecological conditions like endometrial hyperplasias, breast cancer, strokes, osteoarthritis, cholelithiasis, etc. and all. That's the reason this is the topic of interest. Coming to how the obesity is affecting ovulation and menstrual cycle. This is point one. Point two is how it is affecting the endometrium. And coming to male factor, how it is affecting the male parameters, obesity. And last one is how the embryo is being affected by the obesity or excess of weight. First, coming to ovulation and menstrual cycle abnormalities, the prevalence of menstrual irregularities is 30 to 36% of the women with obesity. Anovulation is one more risk in this. Primary anovulatory infertility increases as the BMI rises beyond 27 kg per meter square. The confounders are ovulatory dysfunction. The PCOS is the main confounding factor. Pathophysiology, we all know mostly it is insulin resistance, which is leading to the hyperandrogenemia and the decreased SHBG, sex hormone binding globulin. And one more important thing is ovulatory menstrual cycles. The women who are having ovulatory cycles also, if at all they are obese, then obviously their cycle pattern, the LH, which is the cyclical LH, will be towards the lower side of the scale, and decreased early follicular phase of the LH pulse amplitude and lower total cycle FSH, as well as longer follicular phases. These all will have an impact on the ovulation as well as the oocyte quality. This is the pathophysiology. Next, coming to altered ovarian responsiveness and oocyte quality with fertility treatments. Responsiveness, obesity impairs ovarian response to gonadotropins as well as oral gonadotropic oral agents requiring higher doses and yielding fewer oocytes. Oocyte quality, it is altered with mitochondrial dysfunction, increased ROS species, and abnormal meiotic spindles. Oocytes from women with obesity are smaller than the normal weight controls. This is just an observation. Next, embryo outcomes, lower implantation rates and clinical pregnancy rates. But the ploidy chromosomal normalcy is maintained even in high BMI patients. This is not affected. Next, coming to responsiveness to the ovarian stimulation. In normogonadotropic anovulatory women, increased BMI and abdominal obesity are associated with decreased odds of ovulation in response to clomiphene citrate. Results from a large randomized control trials showed that the live birth rate were greater after letrozole treatment than with that of the clomiphene citrate. Why? Because again, we all know the mechanism of action. Clomiphene citrate is the central acting agent, whereas letrozole is aromatase inhibitor at periphery. In addition, women with obesity treated with gonadotropins for ovulation induction requires higher doses of medication and produce fewer follicles at a given dose. Several large retrospective analyses also confirm that obesity impairs ovarian response to gonadotropin stimulation, increased duration of stimulation or amount of gonadotropin administered, increased cycle cancellation, and fewer oocytes retrieved. Coming to oocyte quality, this is obviously compromised. Oocyte quality is compromised because of the altered follicular environment with higher levels of insulin, other markers of the inflammation, elevated levels of free fatty acids, which were correlated with the abnormal COCs which are formed. Oocytes from women who are overweight or obese, they are of smaller size. We have already discussed that. However, fertilization rates have been inconsistently linked to the maternal BMI, whereas the blastulation rates and metabolics of the developing embryos appear to be influenced by obesity. The proportion of euploid embryos is not different among BMI categories. This is the summary point of the whole ovulation affected by obesity chapter. In 2016, two large retrospective studies analyzed the relationship between BMI and IVF outcomes. Both studies demonstrate a decrease in pregnancy rate and live birth rate with increasing BMI. However, the age-related decline in fertility has a greater impact than BMI on live birth rate at older ages, suggesting that taking time to lose weight before IVF may be detrimental for older women with overweight or obesity. We will discuss this point later. In conclusion, increasing BMI is associated with lower oral agents and gonadotropins and the lower of oocytes retrieved during IVF. In addition, oocyte quality is impaired in both obese models, human clinical studies, as well as animal studies. In linear manner, higher BMI is correlated with lower implantation and clinical pregnancy rates and live birth rates when undergoing IVF or ICSI cycles. Coming to endometrial function, mostly the endometrial function is not coming to fertility point of view, it is not affected. Most of the studies says directly endometrium will not be affected with the obesity, but as we all know, endometrial hyperplasia risk as well as endometrial cancer risk will be increased with more weight. At molecular level, the endometrium from women with obesity demonstrate increased steroid receptor staining and altered expression of other genes that is more pronounced in the presence of infertility. But most of the studies says it has no effect on implantation rates. Miscarriage rates again it is associated with obesity. Odds ratio is 1.31 for spontaneous loss, and recurrent miscarriages it is 1.75. Etiology: women with obesity have a significant higher rate of euploid losses as well. Suggests maternal uterine environment or metabolic factors plays an important role in the embryo genetics. Age versus BMI. Again, age is the more important factor to determine whether we have to go for IVF cycle or take some time and take some time for the patient to lose weight and then plan for pregnancy. The negative effect of BMI is most prominent in younger women and is significantly attenuated with advancing reproductive age. Coming to obstetric complications, maternal risks, gestational diabetes, hypertension, preeclampsia, as well as cesarean delivery, fetal risk factors like macrosomia, stillbirths, congenital abnormalities, NICU admissions, and there are some technical limitations like excess adiposity, limits ultrasound visualization for the fetal anatomic surveys like TIFA, etc. Obesity and male reproduction, semen parameters associated with increased incidence of oligospermia, low sperm count, as well as asthenozoospermia. Endocrine alterations, increased aromatization of testosterone to estradiol in adipose tissue, HPO axis, testicular suppression, as well as DNA integrity will be hampered with increased DF5, as there will be more oxidative stress. ART outcomes, male obesity reduces live birth rate after IVF and increases pregnancy non-viability risk. Lifestyle modification, efficacy, improved ovulation rates and menstrual regularity demonstrated with modest weight loss and PCOS. Male factor weight loss in men increases testosterone and improves sexual function. any erectile dysfunction issues, etc. However, lifestyle modification alone has not consistently showed improved live birth rates in RCTs involving infertility treatment. Coming to medical treatment, most commonly used metformin, though it is not the primary weight loss drug, but yet it improves the insulin sensitivity. The role of these weight loss drugs is like it is beneficial, but along with lifestyle modifications also. The drugs are like phentermine with topiramate, orlistat. These are the drugs, but we should know that all these group of medical drugs, they are under pregnancy category X and should be discontinued prior to the conception planning. Coming to bariatric surgery, this is the best way for the extreme obese people to lose maximum weight. And the procedure selected also Row-en-Y gastric bypass procedure. Pregnancy timing, usually there should be 1 to 2 years gap before planning the pregnancy from the surgery time. Outcomes: decreased risk of gestational diabetes and hypertensive disorders, possible risk of small for gestational age infants and preterm births. There are some weight loss intervention trials as well as outcomes, OWL PCOS study, lifestyle study. All these are, first study is here lifestyle modifications versus OCP usage for the weight loss, buying some time to reduce weight. The comparative study, it is better ovulation rates, but no significant difference in the live birth rates, as well as the other study also the same. What most of these studies says is the weight loss will help the ovulation in people with anovulatory cycles who are obese. The live birth rate will not be varied. Summary: pre-pregnancy weight loss improves spontaneous conception chance, but does not statistically improve the live birth rate. Procedural safety is airway management. Women with obesity desaturate rapidly. Mask ventilation can be challenging. Retrieval data: oocyte retrieval in class 3 and 4 obesity can be performed safely in appropriate settings. May require higher anesthetic doses and 20% longer procedure duration. Recommendations: evaluate comorbidities before surgery. Consult anesthesia teams to develop clinic-specific safety protocols. Summary of evidence is obesity reduces spontaneous fertility and ovarian responsiveness to stimulation. Obesity increases maternal and fetal complication risks. In anovulatory women, weight loss improves ovulation and chance of unassisted conception. In ovulatory women needing IVF, pre-pregnancy weight loss interventions have not shown any improvement in the live birth rates. There is no medical or ethical directive for a society-wide BMI threshold. Policies should be based on local safety capabilities. The conclusion is obesity should not be the sole criteria for denying access to infertility treatment. Counseling should address reproductive as well as maternal and fetal risks. Individual programs should establish policies based on their ability to safely perform procedures, and treatment decisions require shared decision-making, balancing patient autonomy with non-maleficence.